my name is Youri. I'm an inclusive humanitarian action specialist for humanity and inclusion based in Kampala. I'm very humbled to be here today with all the great speech we already had and the great experience that you all have in this domain. So I will focus on humanitarian settings. So that is my specialty, so I don't want to talk too much about other things. For those who don't see me, so I'm a tall white man, young, even if over 35, largely. I have long hair, and my name is, in sign language, is the Y that goes around my long hair. So today we're going to try to talk a little bit about data and inclusive data and its role into advocacy. Actually, there are two. First, the advocacy to get data, and then the use of that data to do more advocacy to get better services. Just a little introduction about HI for those who don't know it. So yes, we say HI, so that's easier. So we are an international aid organization. We work in all kinds of situations, poverty, exclusion, but also conflict and disaster. We work mainly with persons with disabilities and with different vulnerable groups. As you will see, I work a lot with refugees. We work on essential needs and living and improving living conditions. And we work to improve respect for dignity and fundamental rights with persons with disabilities. We are in 59 different countries in the world. We have around 420 projects and 4,700 staff. But we have no activity here in Tanzania for the moment. So just to give a little background about our history and how we are linked with advocacy. So we were born in 1982, so it's a little bit more than 40 years now, at the Cambodian-Thai border. To support young children and young adults that got injured by landmines. So that's how it started, basically. Our first African program was 1984 in Angola, and we worked a lot on rehabilitation, physical rehabilitation, and helping them to get prosthetics, mostly. In 1992, this is our first campaign. We are a member of the international campaign to ban landmines. I don't know if you have heard of it, but it finalized in 1997 with the Treaty of Ottawa that banned landmines, besides for the three big producers of landmines, but all the others signed. So this is a very important landmine for us because that campaign got the Nobel Prize for Peace. So it got a great recognition for all the participants to that campaign. It was not only HII, it was a real, we talked about partnership earlier, very large group of organizations. We also participated to the adoption of the UNCRPD, which we have already talked about, in 2006. We changed our name from Handicap International to Humanity and Inclusion in 2018 through advocacy. From the most English-speaking people that says that handicap was a very bad name for an organization working with persons with disabilities. However, for French-speaking people, handicap is the correct word to say disability. So that's where confusion is. That's now why we are called Humanity and Inclusion. And in France, we are still called Fédération Handicap Internationale. The last campaign we are in currently is called EWIPA. We say Stop Bombing Civilians, and we are also part of a very important large coalition of NGOs trying to ban bombing populated area. So EWIPA is explosive weapons in populated areas. So as you know, in the world, a lot of people get injured because their cities being bombed, not because they are military, but because they're just next to them. So that's the last big campaign. Little map of the world. All the blue spots you see are countries where we are operating. And as you can see, we are not only operating in the south, we are also operating in the north. Because the situation of persons with disabilities in Europe, in the US, for instance, is not perfect yet. So we are still working on advocacy in those countries too. So let me just talk a little bit about what is inclusive humanitarian action, because that's my specialty. So humanitarian action is all actions we take to support people when they are facing crisis or disaster, mostly. So a rapid change in the situation, a shock. Humanitarian action is all action we take in those situations to ensure that we are saving lives, okay? Because people are at huge risk in those moments, and we need to save lives. So not so long ago, in 2016, NGOs, UN organization came together in Istanbul to discuss about their humanitarian, it's called the Humanitarian Summit, and they discussed about the situation of persons with disabilities in those situations. So 2016, that's not long ago. You know, CRPD said in Article 11 that persons with disabilities have the right to the same services in humanitarian action, but until 2016, really nothing happened. And from there, we started to create a task team to develop guidelines on how we should support persons with disabilities in those situations. Before that, there were no guidelines. I talk about that because that's also advocacy. Advocacy led to the 2016 summit that said, this year we're going to talk about disability. It led then, during that summit, to, yes, we need to do something. So creation of a task team. That task team created guidelines. And because of those guidelines, I can do my work of specialist in inclusive humanitarian action. And my job is to ensure that people who are offering humanitarian services are following those guidelines. Those guidelines are really important for us because it's the first humanitarian guidelines that have been developed with persons with disabilities. So there were not only NGOs deciding how we have to do that, but also different representatives for different organizations that participated to that development. Around 300 people participated to the development of those guidelines. So that's also very important for us, and now it is a key document. So I'm not gonna stay too long on that, but I said, you know, it was a very long process to develop those guidelines, around 3 years, because we really wanted those guidelines to show what people thought about their situation, and not only what we think should be done. And so that takes a lot of time because it takes a lot of change in our own behavior as humanitarian actors. Because I have 20 years of experience, so at one moment, you know, you need to be challenged. Because if no, you're not challenged, you think you know, but you don't know. That's how you become specialists, is when you know you don't know. And so it was a very interesting process to, you know, proposing and people telling you, no, that's not good enough. And so trying to find new system with very practical approaches. So the structure is basically background and definitions, because we need to know that we are all talking about the same thing when we are talking about persons with disabilities. The twin-track approach, I will talk about it a little bit after, and the must-do action, I will talk about that too. What we recommend humanitarian response action, what are the actions that they can take directly to ensure a more inclusive response, the different stakeholders' roles and responsibilities, because if you just say we need to do that and you don't say who has to do it, nobody's doing it. That's why in the different tables we saw earlier, there was always who is responsible. Because if nobody is responsible, it doesn't happen. Okay? And then, sector by sector, what are the type of actions you can take? And you even have a book with good practices that is attached to it. So now I give you the 4 actions. So you can see it's not a big thing, it's not complicated. There are 4 must-do actions for all organizations that wants to be inclusive of persons with disabilities. First is ensure meaningful participation of persons with disabilities in key moments, and when we say key moments, that means along the project cycle. So design of the project, implementation of the project, monitoring of the project, evaluation of the project. Every phase we need participation. Then identify and remove barriers to access to services for persons with disabilities. Barriers as a key issue. Empowerment of persons with disabilities. And also capacities of humanitarian actors to understand better what they can do in terms of inclusive humanitarian action. So, and then at the end, and that's why we're going to talk about it today, collection, disaggregation, and presentation of data on disability, age, and gender. So what we need is good data so we can provide good services. All that needs to be done in a twin-track approach. Twin-track approach needs a double system. One is mainstreaming disability wherever it is possible to mainstream it. And the other part is what we call targeted services or individualized services. Those are the services that you need to add to the global efforts to target specificities of issues faced by persons with disabilities. Okay, can be a medical system, for instance, you know, rehabilitation, but it can also be eye surgery access, or those kind of things. Is that clear? I know I talk fast. English is not my first language, as you can hear. So do not hesitate to stop me if I say something that doesn't mean anything to you, okay? So why do we need data? So the first thing that happened is that to say, well, why would we need to use resources to collect data? Why don't we use those resources to provide services to people? So there are three main elements in humanitarian action where we need data. First is the program and the planning. If you don't know how many persons with disabilities you face, and if you don't know what different types of disabilities they have, you cannot program and plan your actions adapted to what the needs are in front. Okay, and in humanitarian action, you may face very different situations. So, if it's war, you will have a lot of injuries to treat. So you need to know how many people will need to receive services for injuries, because if you don't know, well, you will not be able to adapt your offer. Monitor. So if you want to support people, if you're not able to monitor how much you support them, then it's basically you're doing nothing. Because at the end, you cannot explain what happens. And also, more importantly, you cannot readapt your program if you don't monitor. If you know there are 15% of persons with disabilities in the settlements you are providing services to, and if you know that only 2% of persons with disabilities are within the clients of your program, then that means that you're missing 13% of them. Where are they? What are they doing? So you don't know that if you don't monitor numbers. And if you don't have those numbers, you cannot monitor them. And at the end, evaluate your program, because we need to improve every time we have an action. We don't replicate the same project from year to year. And a humanitarian project is usually 1 year. So you need to be sure that you evaluate correctly. And to do that, you need data again. You will have different types of data. You will have quantitative data, as I said to you, but also qualitative data. When we talk about barriers, for instance, you cannot just give a number. It's not the number of persons facing barriers or the number of barriers there is. You need to understand what is the barriers and how people want to overcome that barrier. And the solution is not the same in a settlement in Uganda, in an IDP camp in the middle of South Sudan, or in Yemen that is bombarded by planes at the moment. And the solutions are not the same. What persons with disabilities want in those different countries is different. So you need to have tools to understand what are those barriers and what are the solutions. We have the story of a woman in Yemen who cannot see. The problem is not the bombs. The problem for her is that the road is destroyed, and therefore she cannot move around as she used to be able to move around, just because the road is destroyed. So she's not afraid of the fighting. She's not afraid of anything. She just say, I can't walk. I'm stuck at home now. So she has another situation that what we are used to have in the same setting. So before she had no barrier, and the barrier came just because the road is destroyed and that she cannot go around because it's always changing. So the role is not to take lots of data and then to see, oh, we find a way to use it. Data is something that you plan also. You need to know what you want to know to be able to have quality data. So it needs to be targeted. You cannot go to people and ask them the same questions over and over again every week without providing services. You do it once, you do it well, you have the good information, you provide services. Okay? What we see a lot is a lot of surveys. And you do surveys, and in between surveys, nothing changed. So why are you taking data on me? No, you only take data when you know you're going to use it to do something. So it's very important that you take quality data, quantitative data, and also that it's very targeted to the means that you want to use at the end. And it needs to be analyzed and not just give a bunch of numbers, as we see many times on reports. You have lots of numbers, but they don't mean anything if you don't analyze them. Okay? So now let me show you how it works. So this is a table with a bunch of different surveys that have been done between around 2014 and 2018 in the same area. So this concerns Syrian refugees in Jordan. All those surveys have been done by different types of organizations to understand better the needs in the humanitarian response. This is the prevalence of disability found in each of those surveys. Okay? So this is around 2.5%, and this is about 27%. So we have a big issue there. We are exactly looking for the same number, and we are finding very, very different data. So which one is the good one? We don't know. Okay? So that is a big issue about disability data, is that we often see this. And we know that in the world, in general, it's around 15%. That's the number given by WHO. We kind of agree around that. In Uganda, it's 14.2%. I don't know here. In Tanzania? 9.3. So a little bit under. But that's what you see. You do the same survey, different organizations, different methodologies, and we don't get a good number. So we cannot monitor anything with that. Okay? So why is this happening? There's some reason for that. The biggest one that we see is that it is linked to the methodology used. And one of the main things is that if you use the word disability in your questionnaire, you're going to drop a number. If you ask to people, do you have a disability? Less people will say yes than if you do a study differently. So only that puts you in that list. So in those countries, they ask the question, do you have a disability? And we find population less than 4% have a disability. Just because they ask that. So you have also a data that is taken by a list of impairment. So medical data. Impairment is the medical issue. So if you take by impairment, list of conditions, you're gonna find yourself here. So here we reach under 6%. Why? Because that means that you need a doctor to say you have a disability. So that means that you have to have access to a doctor. And a doctor that is well trained, not the medical officer that comes to your house and just talk to the father and then that's how he knows if there are conditions or not. So if you have a functional approach, so if you go on the impact of disability on the lives of people, then you reach numbers that are closer to what we should have, around 15%. So it is very important that we use the good word. And the last thing that I haven't said yet is the preconception of enumerators. So the people that will come to take your data, it's very important that are well trained. I trained lots of enumerators in my career, and they all do a lot of mistakes. They see someone sitting on a wheelchair, they will automatically put as a disability. But I can show you places where the wheelchair is the only chair they have in the family. Therefore, everybody is sitting on that wheelchair, there's nobody on it. So sometimes it's like that. Sometimes they see someone walking and they just say, oh, no disability. Well, a person doesn't hear. How do you know? So the fact is that those persons, sometimes they just talk to the father of the family and don't go around. For children, it's even more difficult. So we need to find tools that allows good data. And to do that, we need first to define disability. Because we need to know what we are talking about. Who are the person that we need to get data on? Without knowing the definition, we cannot count. It's impossible. So we go from the definition that is given by the UNCRPD. And that's the only one we use as HI. Maybe others use different disabilities, but for us it's only this one. Persons with disabilities include those who have a long-term physical, mental, intellectual, or sensory impairment, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. That is the definition that we will use, okay? And we start from there. Why do we start from there? Because we are not all doctors. And I think George talked this morning about the medical model, social model, human rights model. We are also using human rights model. So our objective, it's full and effective participation. So if that is our objective, we have two parts of the definition. We have the impairment and we have the barriers. So if you go with a list of impairments, which is there, sorry, if we go with a list of impairments, you only have half of the definition. That's only a part of the definition. It's not all the definition. And that's very important, especially for people that have disabilities that have been forgotten, or that are not really well known. I heard someone talking about that today too. Because we are looking not at only the impairment, but the impact on the impairment on the life of people. So how do we get person to go towards equal social participation? So we have person with impairment who interact with an environment where we find barriers. And it's important because preconceptions are barriers in the environment. So sometimes persons do not have any issues to access a service besides the fact that it will be refused to them by someone because they have preconception. That can be one of the barriers. There are many others but one of the barriers is preconception. I work in SRHR, and I have doctors that told me that person with disability should not have children, so he doesn't want to treat them, because they should not have children. So if you have that, any kind of disabilities you have a barrier, directly. You cannot access service just based on the fact that one person decides you should not have access to that service. So that's why it's important that we look at both, and not only at the impairment. So if that interaction is negative, that's what we call disability. If that interaction is positive, that's what we try to call equal social participation. So this is a model. It is not exactly like Latin life. And a lot of things are in between those two. But that's how we define disability. We are defining disability, person who have a medical condition, an impairment, that face barriers in their environment to access social participation, therefore they have a disability. Does that make sense? Do we all understand the same thing? Okay, perfect. And that's what we call the functional approach. To solve that issue of data in humanitarian setting that we didn't have. We had no data. I will explain to you where we were when we started. We first listed why we needed data. We needed data to identify individuals and households with persons with disabilities, know who they are, how many they are, where are they, understand how crisis affected them. So we needed to find them also to discuss with them, to understand how it affected them on a daily basis, identify the barriers and risks they were facing, understand their views and priorities, map their capacities and the resources around disability inclusion, because you guys are resources. OPDs are resources. Sometimes some people in the communities are resources because they want to support, they want to participate. So we need also to be able to map them. Monitor access to and impact of services and facilities. So we need to monitor if persons with disabilities have access to services. So that's why, for instance, in some social services, you will have data on disability to understand what's the percentage of children with disabilities accepted in its school. And if you do that on 50 schools, you will see that some schools are more open to persons with disabilities than others. Measure access to and impact of programs. So, for instance, our program, HI, we monitor the percentage of persons with disability who access our services, and provide evidence base for advocacy initiatives and resource mobilization. And that's where we're gonna arrive after that. So, the tool, this issue of data on persons with disabilities is a long-lasting issue. And the UN had that issue many years ago, because what they found is that, depending on the countries they were going, data were not comparable. They didn't use the same tool. They didn't use the same system. So, as shown you before, if you use different methodology, you will have very different results, so you cannot compare. And that's a big problem in statistics when you cannot compare. It's the same when I started a long time ago for the percentage of literacy. So you have countries that if you had gone to school for 3 years, you were literate. I can show you many different places where children go to school for 6 years and are still not able to read a text. And in other countries, it was a test done by survey on a group of children. Therefore, the system, not the same system to calculate, not the same type of response. So you cannot work. And for disability, it was exactly that, as I've shown you. So they said, well, let's bring some specialists on disability, let's bring some statisticians, let's bring them all together, and we create a group that will work on creating a tool to identify disability in a population. That's what is called the Washington Group. It's called the Washington Group because it's the first place where they met. So it's not a choice of a style or anything, and not for the President of the US, it's just the first place they met. And they met, and they had a clear task, developing a tool to identify disability in a population. So that means in the national census. And they started working, and they were not agreeing. But finally, they developed a series of tools. As you can see, those are all the tools that they have developed. The most well-known one is called what we call the short set of questions. 6 questions. That short set, they developed an enhanced set, because the short set doesn't take into account everything. The enhanced set is 12 questions. But then, you know, you have a lot of, you want more information, so they also develop a set that we call the extended set. More than 50 questions. That's when you want to go very deep. So if you want to work with a small population and you want to understand very deeply what are the different difficulties people face. They developed also with UNICEF the child functioning modules, because as we know, children, they are developing. So because they're developing, you cannot just ask the same question. It needs to be based on the age of the child. Okay? So they have a tool called the child functioning module for 2 to 4 years old, and then 5 to 17. Okay? They had a test specific for COVID. They have a specific test on inclusive education. That's a test on the school to get data. So they developed lots of tools. But you cannot use all that. Especially in census, every question is a huge cost. Because it's one question times your entire population. So it's a lot of time. So that's why the short set is still the most used. And I think it is used here in Tanzania. Because I've seen results of the Washington Group short set used here in Tanzania. It is used in Uganda too. But in humanitarian action, it was not very much used. So what is this set? 6 questions, as I told you. How does it work? What we are trying to identify there. If we want to identify impairment, we are in a very complex system because we need medical. So that's not what we do. We do functioning. So first we decided that it will be self-reporting. So it's not somebody judging, it's you telling. Secondly, we decided not to use the word disability. Because we have seen when we use the word disability, number drop. Because in many cultures, disability is something that fathers, mothers, sisters, brothers will hide. Okay? So, self-reporting, and we say on difficulties, not on disability. So the idea is to ask those 6 questions. So, first question is, do you have difficulty seeing? Even if wearing your glasses. That's only in a context where people have glasses. Do you have difficulty walking or climbing steps? Do you have difficulty with self-care, such as washing over yourself? Do you have difficulty hearing? Do you have difficulty remembering or concentrating and using your usual language? Do you have difficulty communicating, for instance, understanding or being understood? So those are the 6 questions. And we know that the situation is not that sometimes it's either you walk or you don't. So there are 4 levels. So you can respond, do you have difficulty hearing? No, I don't have difficulty. Yes, I have some difficulties. Yes, I have a lot of difficulties. Yes, I cannot do it at all. 4 levels, which allows people to evaluate how hard it is for them to perform that daily activity. And it's a daily activity. Hearing, washing yourself, walking, seeing, communicating, remembering things. So when you see those 4 levels, you can picture yourself. That means that 2 of you may have exactly the same impairment, but not have the same impact on your life. I'll take a simple example. If you live in the mountains, it's way more difficult to walk, even if you don't have a disability. So that means that it is really important to know what is the experience of the person. Some people are less tolerant to pain than others too. And it's not for me to judge, it's for the person to judge what is his reaction. And that allows us to not have a perfect system, but a system that gives us an idea about the difficulties people are facing to perform daily activities. If I know I have 15% or 20% of people that tell me that they have difficulty walking, a lot of difficulty walking, and I put a health center on the top of a hill, I know they will not come. Or I need to find a system to help them to come. That's how it works. If I know that I have 10% of people that have difficulty communicating, I need to put in place a system for those 10% to be able to communicate with my physiotherapist. Because some donor told me, yes, but it's a physio. And I'm like, well, so people with hearing difficulties don't have leg pain sometimes? They cannot have an injury? Because he thought that, well, only people with physical disability will come to a physio. But no, we all go if we need. So, you have to understand that, because now you have levels. And even people that have a little bit of difficulty, it's still important for us to know. So usually we consider a person with disabilities, person that says, I have a lot of difficulty or I cannot do it at all in one of the answers. That's the demographics. So if you have a population of person with disabilities, that's those 2 groups are the ones that will be considered. But that doesn't mean that you cannot use different parameters. You have 6 categories. So it's a really interesting tool for us. So we tested it in humanitarian settings. Remember, I'm talking about humanitarian settings. In development settings, sometimes you can use better tools than that. But in humanitarian setting, it's a crisis. You have to respond tomorrow, or even yesterday, David. So you need to do a tool that gives you good information rapidly, and that one is specifically useful. So it was validated as relevant for understanding the prevalence of the different types of disabilities among the population that we were targeting, understand the level of access of persons with disabilities to humanitarian programs, because what we did, the test is, you use it on the whole population, and you use it also when accessing services. So you can compare if the percentage of persons with disabilities in the population is kind of the same than in your services. If you provide education, and you know there's 10% of children who have a disability in the area you're working in, but you only have 2% in the school, you know you're missing 8%. So it was considered relevant for that. And to disaggregate all your key program indicators. So that's for any kind of NGOs that wants to know if they are accessible for persons with disabilities and for what group of persons with disabilities. But also, if you do a client survey, for instance, to see which group are happy with your service and which group are not happy. You just add it, you have age, gender, and now you can do disability too. So that means that you can also do women with that type of disability, older person with that type of disability, older woman who can't see, you can do all that in your analysis to pinpoint who is the group that is not coming, who is the group that we are failing to provide services to. And that for us, as a humanitarian actor, is very important to understand. Because our role is to provide services to the most vulnerable of all. We say, you know, the furthest behind first. That's the role of our humanitarian organization. If we are not able to do that, we are not responding to our core business. Okay? The simple fact is that if you have a doctor is in front of someone who has a cold and someone was just got his arm exploded by a bomb, who does he need to serve first? Well, it's exactly the same. The one that is the most in danger, you serve first. So for us, it's the most vulnerable because that's the person who is most at risk of having a threat on their life. If they cannot access a doctor, they cannot access education, they cannot access water, food. Okay? Am I clear? I know it's the end of the day. I know I'm talking data. I know you're all working in development and now I'm talking humanitarian. I think I have all the difficulties, but I'm trying my best. Okay. Thank you. So, to complete, because that's only one tool, now we have prevalence. Fine. That doesn't mean what is the issue. If they're not coming, why are they not coming? So we add different types of tools. So when we know that people are not coming, what we do is that we do barrier and facilitator assessments. So we assess our services to understand what are the barriers and the facilitators of our services. How do we do that? Talking to people. That's the only way you can do. So you have interviews with persons with disabilities, interviews with service providers, interviews with key informants, and you try to understand the best way possible what is the main thing that you have. You do focus group discussion, and you try to understand why are people not coming? Well, why are people coming? Because if you understand why they're coming, you like boost that part to be sure more will be coming, because that's what we want. We do also disability-specific needs assessment, because needs assessment are really fast. Sometimes you miss stuff. So if you see that groups have more difficulty to participate to your program, or are invisible in the community, which is the case, for instance, a lot for people with mental issues or people with intellectual disabilities, they're often invisible in the community. So you will try to reach out to them to do some specific assessment to understand what do they have access to, what can we help them to, how can we help their families to, because that's important too, right? Families is the first respondent. So sometimes you need to target the family. It's not only the person that has a disability that you target. Inclusive feedback and complaint mechanism. This is a very important tool because that's the way you communicate first with people. So if people cannot complain, they cannot feedback on what you're doing, then you don't get the good information to change your services. In Uganda, the main feedback and complaint mechanism for the humanitarian crisis, we are talking about 1.5 million people in Uganda, 1.5 million refugees, is a hotline. And I know my friend here will have a lot of difficulties using a vocal hotline if he wants to complain. He can voice his complaint, certainly, but he will not receive the feedback. So we need to adapt feedback and complaint mechanism to the different type of difficulties people may have communicating. If we don't do that, we exclude some group of being able to complain or to receive a feedback. And so we are not gathering enough information on how to improve our own services. Okay, so, and inclusive accountability to affected population tools. That's also very important, especially if we want people with disabilities to participate fully in the humanitarian action. The accountability to affected population mechanism. So this is more than just a feedback and complaint, it's also the mechanism you use to explain what you have done, how it worked for you, and how people can discuss how it should be improved altogether. But usually it is done through big community meetings, where you have 300 people or 400 people. So I can tell you, for having lived that, you have to be strong to talk. And a lot of people are not strong to talk, or they are being bullied in not talking. Because the people that have the most voices are usually the ones who receive the most services. They're the friend of the community leaders, or the friend of the rich person of the community, and they will want to keep that power. So your role is to break that down, to ensure that when you explain what you're doing, you're explaining it to everybody, and everybody has the right to discuss with you on how you should improve it. Okay? We're still all there. Yes. So, that's the last part. So when I arrived in Uganda in 2017, when we reopened our program, HI was not there since 4 years, since Uganda was declared landmine free. I arrived and I asked, okay, where is the data on disability? So they showed me 1% of the refugees had a disability. 1%. And less than like a very, like 1% of those 1% had, for instance, mental diseases, which is totally not aligned to any kind of things I've seen. So 1 to 1.3%, and that was the even individually profiling exercise. So that means that that was done by going door to door. So I was wondering, but how do you do that? What's happening? Was no analysis. Disability, the word disability appeared only twice in the old refugee response plan, and in some sector didn't appear, like livelihood, economic opportunities. Bizarrely, the word disability was not in the plan. So basically, the information they had was a copy-paste of the global information that we say, persons with disabilities have difficulty to access services. We know that. But which services, how, why, all that didn't exist. So that means that because it didn't exist, nobody took care of it. Nobody was even asking the question. There was no data, no capacity to monitor, no capacity to take people accountable for the service they were not providing. So what did we do? Just before COVID, because that's when we started to move on that. Luckily, COVID came and didn't delay everything by 2 years, because you couldn't go to the field anymore. So in the field, what we did, we directly engaged UNHCR with the lead organization in Uganda. So went to them and said, okay, you signed the Charter on Inclusion of Persons with Disabilities in 2016, where one of the 10 commitments is data. Where is your data? So they said, oh, blah, blah, blah. But some people there were listening and said, yeah, you're right. So it started to move inside that group of people. We also engaged in working group and in all the coordination bodies. So we went to that coordination, we talked about a person with disabilities, we did small-scale studies, very small scale. Just take one village, one group, and you do a little study and you show the result. And you say, okay, I went to that village and I got 17% of persons with disabilities. How come your data say 1? So that's how we did. We presented to partner directly. We offered capacity building. And in the same time, that was in the field, In the same time, our HQ was working also with HQ of UNHCR and of other partner organizations, remembering Charter for Change and Istanbul Summit, telling them we are developing ISC guideline that talks about data on disability. They talked directly to the specialist on disability inclusion in UNHCR that luckily was an old staff of HI, so that we knew very well. And we had also engagement directly with donors, especially ECHO. At that time, it was DFID, I think, for UK at that time. Now it changed, but at that time it was DFID. And DFID was really a step further already. GFFO were the Germans, and for GFFO we developed a project with them where we trained GFFO staff in the Ministry of Foreign Affairs in Germany. So we did all that at the same time, at HQ level and in the field. Why? Because when arrived the time of doing this new individual profiling exercise, we said we want Uganda to be pilot. And Uganda Bureau of UNHCR and of the Office of Prime Minister were already ready to be the pilot, because it has been 3 years we were talking about it. So when they prepared it, we engaged and we said, okay, now we need to include disability and we need to include MHPSS. And they say, yes, we know those are two main gaps. So we did an agreement with UNHCR, another organization called Tutaprona for MHPSS and us on disability inclusion. We trained their enumerators. So we used resources that we took from ECHO, because ECHO was on board too, and now it's an obligation to use Washington Group for all ECHO programs. So you see it moved really fast. UNHCR developed their own questions. So they took the Washington Group short set and they added 2 questions of the enhanced set. There comes the compromise. Or minimum acceptance was short set. We wanted an enhanced set plus child functioning module, but we knew that if we have the 6th question, we win. We had 8. Woo! Big party, we need to enjoy our results and our successes. And also important, we coded them. Because you know UNHCR, what they do is that when they have a situation, they code it. It's a code. You're not a person with a physical disability, you are PSN, deep for disability, there is a number. That's how they do. So we coded them, so automatically when person responds to those questions, it directly shows the good coding, and therefore directly the services that goes with it. So, and now they implemented it, first time, and now we have between 7 and 10%, depending on the settlement, because we know that in some settlement it was done well, and in some others a little bit less well. Not perfect, clearly not perfect, but this is 7 to 10 times more people identified than before. And what does that allow? Disability is one of the 3 major objectives of the new refugee response program. Because now they've seen that the situation of person with disability is really bad in the settlement, that it's not just 1% of the population, but around 10, that they face very strong barriers, that we don't know much about it, and that nobody is taking care of it, and therefore that we are not fulfilling our mandate. So persons with disabilities are now considered as one of the major vulnerability group that needs targeted action and that needs a monitoring. So there are now indicators on how a person with disabilities access to services. So what I wanted to show you is that from a situation where we were nowhere, yes, it took 6 years with COVID, so like 5, we can get somewhere, okay? And with a very targeted approach. It was just put some data. So it was including minimum 6 questions in their own tools. We didn't ask a new tool, we didn't ask new survey. We just wanted 6 questions in that new tool. You change the vision that all the humanitarian world has on one issue, which is persons with disabilities. For me, really, it was from going invisible to going first page. Because everybody asked us and asked different OPDs to participate to their program because of that. It's still not perfect, huh? Far away from perfect. We have a long road in front of us. But I think, it gives something in now the people are ready to tackle it. And they have to. And in the same times, a lot of things came together. So what really was interesting from our experience from that is the coordinated efforts at international and national level that really worked great in this example. The compromise, the consensus, and the step-by-step. So when they said, oh, we don't have money to train the enumerators, we put that training into our ECHO proposal. And we went to see ECHO and say, oh, look, they don't have money to do that, can we do it? ECHO said yes. They said, well, we cannot put 12 questions, we can only put 8. We said, okay, we don't know how to code it, let's do it together. All that is, sometimes you have to sit next to them. Don't expect the person that you want to convince to do the work for you. Okay? If you see nothing is moving, write yourself. They don't have a SOP, I'm producing a proposal SOP, and now you have a SOP. So now you better review it to make it your way, because me, that's what I'm proposing, and I'm telling everyone you have it. Because it's you that want something. Well, it's you, not you alone, but it's us that want something. Okay? So you need to facilitate the job of the guy that needs to say yes. If he needs to say yes and he sees he has like 6 months of work by himself in front of him, too harsh. But if you were helping him, you bring him to the different meeting, you prepare a document, you prepare the studies, you help him get there, he sees the interest he has in going with you. So provision of means, that's what I said, we trained, we paid for the training for sometimes. The favorable international context, and yes, the SDG we talked about is the leave no one behind. It's a word, and it's true that in the SDG we don't really see where it brings us and what is the real engagement of the international community. But every time you bring that word, there's a little stress in people because they know it's going to be hard and they want everyone that can help to help. Because it's a stress. Because we can show that it's not working perfectly. So just remind them, leave no one behind. Remember that? And then the last thing is the database advocacy. So the little studies we did, even if they were really small, sometimes during COVID we interviewed 50 people, only 50 people, to understand what were all the issues they were facing because of the COVID situation. So it was really not complicated. They were there. So and we couldn't move. But only that, and bring that forward to working group in front of everyone, is so, oh yeah, it's true. Those people, they have no access to what we are doing at the moment. Information on COVID, this was what they call Boda Boda Talk Talk. I don't know if you see, it's the motorcycle with the big sound system in the back. That's how they were doing it. So, for instance, after 3 months, we had the authorization to add sign language translator in it. So they were stopping and they were going door to door to ask if there were people that needed sign language translation. It was little, but it was an effort. Because we needed that little push for some of the people. But it's through those kind of study that you show that people are complaining. If you're not doing it, a lot of people, they already have a lot of difficulties. They are tired, they are usually excluded from part of the community, so they're not going out. They're not gonna come out if you don't help them to come out. So you need to do that. Those little studies showed that we were missing a part of the population. So I think that's when it comes down, and a little bit earlier, I was listening to Blaise, and I read all the notes. He said, you know, you have to do all these steps, and I ticked all of them, and so I was so proud of myself without knowing them. But that means that actually it is a good list, because we did that without really knowing it. But that means that, you know, if we try to think through those steps, they're, I think, all important, and that's showing that, you know, even I'm sure you guys, when you do advocacy, you also tick all the boxes. But that's another way to find a little bit of, you know, being happy about our successes, to tick all the boxes of Blaise. So I will stop here. Thank you very much for listening to me.